This is the March meeting for the Local Alcohol and Drug Planning Committee. A reminder that as a public meeting, it is being recorded in accordance with public meeting laws. We also have been posting these on the website so that folks can go back when we have featured presentations or other community updates and get updates on what is going on. Should we take a roll call and look at approving the minutes from February?
Yes, thank you.
Thank you.
Jack Adkins.
Present.
Do you want to do both at the same time, Eric, or you want me to do it twice? I don't know if you just
I just thought of that too. No, I think you're right. So if anybody had a chance to look at the meeting minutes from February of our members, we would either take discussion or entertain a motion to approve.
A motion to approve the minutes from February.
We have a motion from Michael O'Malley. Do we have a second?
Second.
And who was that second? Just
That was me peeping.
Oh, thanks, Sarah. Oh, nice. All right, great. So we have a motion and a second. So we will be voting as we take this roll call, and we can start again with Jack Atkins to see if he approves of said minutes.
Approve.
Ron Dunn had an excused absence. Eric Geyer.
Approve. Thank you.
Justin Hahn also had an excused absence. Amanda Eisenhower. Okay.
Yes, sorry, approved.
Okay, here. Thank you. Rosemary Jernigan.
Approved, thank you.
Lisa McCready.
Approved.
Michael O'Malley.
Approved.
Heather Filth. Nick Wrighton. I believe he also had an excused absence. And Sarah Smith.
Approve.
Thank you.
Just to give a little context, we've been hoping and working with our CCOs for quite a while about finding some data that we can present and use to gauge progress within our community. And so we're excited that our partners have been able to come to the table today, and we look forward to what you have to share. So thank you, Jeffrey.
You bet. You bet. What I just want to say to folks today is that, this is sort of an introductory data pool and share. So these are the types of data we have available. And so, after we both present AllCare and JCC, if there's any feedback in regards to, is this information helpful? If not, what might be helpful would be great feedback to get from the group. And then based on that feedback, we can start to put together some more regular data pools that we can present very briefly during this meeting. So what we have here in front of us is the substance use disorder visits. So this shows unique Jackson County members for AllCare. In Q4 of last year, we had 15,720 unique members. And we just put this basically together in a simple kind of bar graph here. The first section there is outpatient SUD treatment. So of our 15,720 folks, we had 292 unique members in outpatient treatment. That would be local outpatient treatment with either ARC, OnTrack, Culpia, or Phoenix. The second bar shows the number of unique members accessing Detox. In the Q4, that was 18 folks in Jackson County. The third bar shows it's labeled inpatient rehab. Essentially, this is residential treatment for folks in the Q4 of last year. For AllCare, there were 32 folks. That represents both local residential treatment and regional residential treatment. So we were contracted with roughly a dozen residential treatment facilities in the state of Oregon. Most of those are out of the area. So we had 32 folks in residential treatment in the Q4 of last year. And then the last two, so these are hospital-related statistics. And so the first one is inpatient stay. So this is for folks who were actually admitted to a local or regional hospital for a primary substance use disorder diagnosis on the hospital claim. So that means that the first diagnosis was, alcohol abuse, alcohol dependence, other stimulant abuse, opioid dependence, cocaine abuse, etc. So that was 12 folks admitted to hospital stay in the fourth quarter of last year. And then ED visits, these are visits where the primary diagnosis is substance use disorder. There were 53 visits in the fourth quarter of last year. Now, I just want to say something about these last two categories. Over the weeks and months, you've heard me go on about how the flow of SUD presentations at the ED just continues to grow. And some of you may be looking at the ED visits for the fourth quarter and say, well, 53, that's a lot of visits, but that's not, an astronomical amount. So that is just the visits where the primary SUD diagnosis is a substance use disorder. When we open that up to the secondary diagnosis being substance use disorder, it jumps to 171 visits in the fourth quarter. So just kind of keeping in mind that these are situations where the primary diagnosis would be like paranoia, hallucinations, more medical things like cellulitis, endocarditis, diabetic ketoacidosis. Someone's there for medical clearance, a motor vehicle accident, gunshot wound. So I just want to sort of reiterate that even though the 53 visits, may capture directly what we get from claims, it doesn't sort of show the whole picture when it comes to, substance use disorder related visits to the ED. I hope that makes sense the way that I characterize that.
No, it really does, Jeffrey, and thank you for putting that into some context. But I still think 53 in the ED, because the complexity and the intensity of those cases, they're really difficult, and those are really serious cases. If a case presents elsewhere, they usually have some sort of stabilization, a baseline maybe. But if they're in the ED, boy, I think that really speaks to how difficult those folks are to find resources and supports for.
It really does, Eric, and I want to be also just reiterate that these are unique member visits, and of course, all of us on this call know that there are. I'll just throw out the number: 5% of folks who continue to show up regularly at the ED. I have, some folks in Josephine County right now who are in the hundreds in terms of their number of presentations in a calendar year. So again, 53 shows, the number of unique members, but unfortunately we have folks who are, repeats pretty consistently. So it's not quite an accurate picture, but based on the information that we wanted to present today, that's the number we have. So let me see if there's anything else here I want to mention about this. The data is only as good as what's in our system. So, this is all sort of claims-based data in terms of outpatient treatment, detox, or residential. Generally speaking, we receive claims within a 3-month period, but there are always some outliers, So if we haven't gotten the claims yet, this data may not be fully complete. So I just wanted to make sure that I mentioned that. So that's about all I have. We tried to kind of make it as digestible as possible. Hopefully we succeeded in that. Are there any questions that I may be able to answer?
I have a question. This is Lori Paris, Jeff, and
yes.
For those ED visits, sorry, you just moved your screen.
Oh, so sorry.
For the inpatient stay and the ED visits, do you have a cross-reference to how many of those individuals are also enrolled in treatment services?
I don't at the moment, but that is something we could certainly do with ease, Lori. That's a great question.
And that would be great data to see, I think, too.
You bet.
Thanks.
I think along the same line is linking people into primary care when possible, and the case management, and just, you know, the ideal of primary care is birth to death help. So I was thinking about just the financial implications of all of this that you've presented so clearly. Thank you. But yeah, just what do we do with this?
Right, Sarah, thank you. You know, what I wanted to, I didn't know if we had time to get into it, and I'll keep it extremely brief, but I mean, what I wanted to...
We have time. We have time. Please.
Okay. I'll slow the roll. You know, in terms of what I do with this information when I get it, so I'll look at the last two categories, inpatient stay and ED visits. So as many of you are, I'm accessing collective medical several times a day, and I get real-time notifications when folks are in the hospital. And so if I'm able to get a notification while someone's at the hospital, I reach out to either an entity that the person is already involved with, and I find that out through claims. So some of you at On Track and ARC, you know, you know that I've reached out to your community-based folks to ask for follow-up. Allied the same, and so I'm trying to kind of do a live time outreach, right, while we still have the person as somewhat of a captive audience. Oftentimes, though, as you all know, folks present late in the evening or in the very early morning hours, where of course I'm not monitoring collective at that time, so I generally get that information the next day. And still, I make sure that I follow up with either the treatment provider entity or an entity that I would like to follow up with the member. Sometimes that's options for Southern Oregon. So if the person is already open to options for mental health services, I may contact their SUD person there to ask for follow-up with that person as well. So we do make sure that we outreach to at least the substance use disorder provider entities, and we can look at whether reaching out to the primary care entity might behoove us in that situation as well.
I think Birch Grove, where I'm working now, is kind of a natural fit. I could talk to you offline, although we have the CCO dilemma, you know.
Right.
So,
right.
But a model like that. Anyway, I really appreciate what you're doing.
You bet, Sarah. And when before the prime care contract situation, I was working very closely with Hazel and other folks at Birch, and it was a seamless relationship, and I think it sort of mirrors the relationship that we have with other providers right now as well. But as everybody on the phone knows, I mean, quick outreach is fantastic, but sometimes it takes a lot of outreach, and unfortunately, sometimes a lot of hospital visits before we actually get the person in a place where they're ready for treatment. So we just continue to do the best we can. Are there any other questions or comments?
Jeffrey, I would just like to express my gratitude and say how helpful this is. I've been a member, I think, for 13 plus years on this committee, and there's others of us that have been here a long time. And I understand this isn't the entirety of the services provided by our local providers. I understand that this isn't the entirety of SUD services in our community, but as a place that we can kind of use to say, hey, are folks accessing more or less care? Is the need higher or lower? This is a really good start, and it is digestible. So I'm grateful on both of those counts. So thank you so much for your work there.
You bet, and I'll take some of the feedback that I received from Lori and Sarah and you, Eric, and we can kind of see if we can put together something that's even more helpful in terms of a data pool, and see if we can find, again, not a lot of time, but find some time during these meetings to present if people feel that it's useful to them.
My sense is that certain, oh, go ahead, Lori, please.
I was just going to say thank you, Jeffrey.
You bet. You bet.
And my sense is that at least on a quarterly basis, this would be extremely helpful, particularly as we embark on the new 110 reality. After Measure 110, are folks accessing more care, less care? Are we still able to engage them? And I think this would be a good way to help us tell that story and tell what's going on in our community. So thank you.
Eric, this is Dane at HIV Alliance.
Hey, Dana. Yeah.
We have our 2 prime peers also in place now, and this might be a place where they could be reached out to connect with some of these clients too.
Thank you, Dane. I know Prime Peer has been one of those big pieces that the states really wanted to roll out, and the fact that HIV Alliance has been our local rollout of that, that's exciting to hear that they're up and running. So thank you. All right. Well, we also have Julia Jackson. Thank you so much, Jeffrey, for sharing. And Julia, you have some information, I think, to share.
That PowerPoint, I'm only going to go over a few of the slides just specific to this meeting, but that PowerPoint, I'm totally fine with being shared with the group, and it includes quite a few other slides that also include data for mental health, behavioral health strategies in general and whatnot. And so the whole thing is fine to be shared as well. So I just want to second a lot of what was said. Obviously, we have similar systems for how we collect data. There is a claims lag. And so we look at data that really the most solid data that we have right now is what happened in 2020, and specifically, December 2020. And then next quarter, we'll be able to finally start really catching up with that claims lag and seeing what's happening in January and whatnot. So I want to jump to the third slide. JCC members, just as of March 1st, we have 55,926. JCC members, that slide also just shows where the majority of our members are falling in primary care for their primary care home. And then the next slide is mental health utilization. So the slide after that is member services who have a substance use disorder. If the first bullet point is focusing on December 2020, so for that month, of those 55,000 members, 7.6% are accessing SUD services. So that doesn't mean that 7.6% are SUD, it means 7.6% of the total membership are accessing SUD services. And that's in both a primary care or specialty behavioral health setting. If you're looking at just folks who are accessing SUD services in a SUD setting, then it's 5.9%. And there's a little bit of a breakdown in age there. And unfortunately, with our claims, with our data system, we're working on fixing this. But for right now, we don't have historical yearly averages like we do for mental health in the previous slide.
Okay. Jennifer, Julia, excuse me. Is it going to break my heart to find out what a child birth to 5 accessing SUD services is suffering from? Is it somebody who's born addicted?
I know.
Oh.
Yeah.
Okay.
It's related. It's related to that. Yeah,
Okay.
They're certainly not struggling with an alcohol use problem. And,
No, right.
at 5 years old, that's for
Okay.
sure.
No, right.
But then skipping to SUD treatment trends. So for residential, 241 members were served in our residential provider settings on Track and Arc. There were 307 visits for those 241 members. So that's an average rate of 1 visit per member, but obviously there were some members that had more than 1 visit. And so that's kind of how you read the yearly averages down there, that for example, 2019, there was 206 members, but 270 visits, and so on. The length of stay was an average of 36 days per admin.
And so that's for the year. Is that right?
That is for the year, correct.
Okay.
Thank you. That is for 2020. Okay, and then the next slide is Detox. So that was residential, and now we're looking at Detox. And there's several categories that folks could fall into here. And I just want to highlight that, so, when we're going to look at hospital data, like hospital admissions, similarly to what was presented, we're going to look at hospital admissions for physical health problems, not for, you know, what's obviously contained in this slide, which is going to the ER for detox related treatment, right? So here you can see for ER detox, again, this is for the whole year, 628 members, but 1,245 visits, so an average of 2 visits per member. But if you look at the bullet point in, let's see, yeah, if you look at the bullet point, you can see that over the years, there is an average of about 2 visits per member. And then you can note the numbers there.
It looks like there was quite a jump though from 19 to 20. Are those numbers comparable? Were there anything different in the reporting?
Well, there was a membership, you know, there was changes in membership.
Oh, right.
So, yeah, so that is something to consider.
Not quite apples to apples then, okay.
Yeah, there was about I believe it was a 20% increase in membership, so you can kind of apply that. So then you kind of follow the same logic in looking at the other admissions. So inpatient was 173 members, 875 visits. That's 5 visits per member, which is not a good, you know, it's just kind of an indicator of that's not the best setting for them to get treated. Because then you look at our ARC detox treatment provider, and then, you know, we're back to an average of 1 visit per member. So in level 3.2 and level 3.7, 2020 served 232 members with 280 visits. And then you can see the trends year over year for 2019, 18, 17, and 16.
Gotcha. Can
But
you talk
again, each of those years for detox was also an average of 1 visit per member.
And Julie, the difference between level 3.2 and level 3.7 and what they represent?
You know, so the bulk is 3.2. 3.7 is often referred to as a clinical detox, and the majority of those folks are actually like they're stepped down, and then they actually start residing in residential while they're still weaning off of that level of detox. And so when I had followed up with Danny, because I had a question on that also, she was really a great resource of information for me on that. And she said that the number's really insignificant. It's really, really small. But from time to time, a few folks will transition to that level of detox where they can start living at the residential center, but they aren't yet transitioned out of that level of care in terms of like the medical care and whatnot that they're receiving, like the nursing monitoring and whatnot.
Okay.
The emergency room slide, I have 2 slides for emergency room, and we can go over emergency room for SUD. So these slides are showing folks who had, you know, either a mental health diagnosis, or in the case of the slide that we'll review, folks who had a SUD diagnosis. They're presenting to the ER for physical health needs. So we look at this because obviously we want them to get their physical health needs met with their primary care provider. And so there's some care coordination that needs to happen here. So we read this data in terms of member month, because in any given month, a member could be added to the network. And so, for example, in December 2016, it was a rate 3. And in order to understand that, I have the asterisk. That's essentially for December 2016, it was 36 visits for the 27 member month. So if you look at the rate, it goes up in 2017, down in 2018, and then it has the highest peak in August 2019 with a 2.0 rate. December drops, but it's interesting. August again is a peak month for some reason. At 1.6, December again drops. And just to again put that in context, what that meant for December of 2020 is that there were 61 visits per 54,318 member month. So of folks who had SUD diagnosis, there were 61 visits for those folks accessing a primary, like a physical health need in the emergency room. I don't know if anyone has any questions, or I could go back over some of them.
I find these fascinating. If we go back to the one that was about follow-up from Detox, it seems like those are really positive in the sense that people are connecting to follow-up services from a detox setting.
Yeah, it is. Let's look at that one, follow-up post-detox. So, so you have the years in parentheses there, and there's different categories. There's follow-up after 2 days, being discharged, follow-up after 7 days, follow-up after 15 days. And obviously, the rate of follow-up does increase and or improve, the further amount. So 15 days follow-up is obviously going to be the highest number. But also, if you look within the years, there has been improvement over time in each category, generally speaking. So just a lot of kudos to the provider network for everything that they do to add to that, because it's definitely a cross provider network number. It's not landing on any one provider. We do have the ability to look at per provider data for follow-up, but generally speaking, this is kind of like a collaborative effort here.
Okay, that one's really helpful. We do have some time, so if there are other slides you'd like to share, or if folks have questions.
I have a couple questions. One of them is, when we're talking about people going to the emergency room for medical needs, I can think of quite a few that a person could have who's in trouble with opioids. So I'm kind of, is that SUD, is that medical, or, and the other one is just kind of thinking about the people that are behind the numbers. I'm curious about how many of the ED visits could be like overdose visits, or like, what do they kind of break into?
That's a really good question. So I would have to dial into the specific claims more to get some trends on that, and I'd be happy to do. I don't have that with me now, but it would be interesting to really clarify, like, at what point does the issue, like maybe they come in, presenting one way, and it's flagged as physical health and just general, and then it turns into a SUD need or detox, or something like that. But I would definitely have to dive into the data more to find that out.
Julia, is there anything you'd like to share further beyond this? We do have a couple minutes. And
I could try. So initiation and engagement, which is the very next metric.
Got it.
Our target for, and I have to the side there in that red flag, it's kind of explains what initiation and engagement is, but I have the target for 2021 as 43.9% and engagement 18.1%, and you can see in present performance across the network that we're getting very close to that. And so I would just give kudos to everyone. This is a metric that really does require a lot of collaboration and just working together in terms of folks landing in a physical health setting and then getting their follow-up engagement needs met by a treatment provider. So I think that that's a great kudos that we're working and getting better there. It also, the metric is a little bit deceiving because it's about dropping the right codes, as well. And so sometimes the work is happening. It's just that the codes aren't capturing it as well. But I just wanted to point that out, that I think we have a lot of awesome collaboration going on. And then, the telehealth trends also are pretty interesting. This telehealth trends 2020, this slide just kind of shows what happened in 2020 with COVID and with all of our providers. This is the entire network, primary care and behavioral health providers, and their usage of telehealth services. And then you can see for JCC when the fires hit and it decreased, so that's pretty interesting. We are down in general from April, but also, you know, there's restrictions are lessening. There's more face-to-face time, so that seems pretty typical. It'll be interesting to see what happens with telehealth services as vaccinations, you know, vaccinations increase and more face-to-face time, and yet providers and their clients are discovering that for some, telehealth continues to be the best avenue. So it'll be interesting to see long-term what happens in terms of telehealth trends.
No, I think that's fascinating. And I'd love to hear from our providers today when we do some report outs about what their sense of that is, you know, going forward, but also when we look at things like initiation and engagement, which I think are great indicators rather than just like assessment and follow-up. I think initiation and engagement, you know, if I just have to telehealth with somebody and give them some of my time via telehealth, I might be more willing to put my toe in the water rather than go down, get in line, sit down for the whole process. So whatever we lose on a human front, we might be gaining on a client-based, okay, that sounds like a way I could give you that much time, right? So I don't know what the numbers will ultimately show, but I'd be real curious about what that is from our providers today.
Yeah, and I think that that's the point, right, is that I'm really excited to share data along with AllCare, and we acknowledge too that it's only part of the story. And hopefully what it does is it prompts everyone to discuss the story behind the data and also ask questions like, I love that question about, tell me more about those emergency room visits. You know, what are these visits specifically? How do they transform, you know, into the different types, and what is the data behind that? And so that was leading me to my other point, which is please tell me, you know, anyone in the group, like if extra information is needed for next time, or like a different piece that I could bring to the same type of data presentation that would help inform folks more, or was something missing? Is there something that extra that we didn't even touch on that would be helpful to cover next time we review data? So that was, you know, as we continue to develop this, those were some of the pieces that I wanted to ask.
It's Mike O'Malley. I would be interested in, if you can tease it out at some point in the future, the number of co-occurring disorders, folks that have both mental illness and SUD, and which is primary and which is secondary.
Yeah, definitely. I can get that. I can put that on the list.
Any other questions for Julia? Well, Julia, thank you so much. You and Jeffrey have kind of taken the ball and ran with it. Both of you had heard the request and were able to come up with incredible information that is digestible. And it, you know, I certainly there's some acronyms I need to brush up on, but it's really exciting to see that we can track this and get a sense of what's happening within our community. Again, to foster different conversations and look at different needs within our community and identify things that are working well. So all of those things I think are really exciting, and I'm grateful to both of you. So thank you.
Thanks for the opportunity, Eric.
No problem. Happy to do it.
Right. So our agenda mentioned Mr. Swanson, who was unable to join us, it looks like at this point, from Oregon Recovers. And so we'd still like to hear eventually about some of the different things happening at the legislature that affect alcohol and drug services in our community. We're lucky to have data presentations for the core of what we're doing. I don't know if Tanya or Jim Shames were able to join us today. Again, they get the COVID excuse still as they're on the front lines for what we're doing there. But that does bring us up to local treatment provider updates, and starting with the Addictions Recovery Center, Kim Ovison. But Lori, I see that you're here. So the ARC.
And actually, Nathan is going to give the update.
Perfect.
Excellent. Thanks, Lori.
Great.
Thank you, Eric. So ARC's rolling along. We're still working primarily remotely in our outpatient milieu. We have our residentials are both full. Detox is full. And we've also kind of beefed up our community engagement with Ben Spence's team. He has another CRM on staff, and they've been going out on the Greenway with access and doing some more community response, which has been great. It's been really positive interaction with the folks out there and in the community.
Excellent. Excellent. Always good to see you, Nathan. Thank you. Jody Riel from Allied is here, I saw earlier. Jody, are you still with us with an update?
I am, and there's
Awesome.
really nothing new to going on at Allied. We're still doing our groups over the phone and still taking patients daily and doing our one-on-one. So we're doing good.
Great. Justin with Boulder Care, I believe you have a guest with you.
I have Jody Boswick with me. Jody is in the room. She's the lead nurse practitioner with us. And she also is in the area.
That's exciting. Welcome, Jody. Thank you.
I'm like, Jody, say hi. This is a great group of people. We all love each other.
Perfect. Well, thank you for letting me crash your meeting. I was excited that Justin graciously invited me along. But yeah, I live in Southern Oregon. I'm a psychiatric nurse practitioner and love working with Boulder.
So can I ask a Boulder question? Just like so if I were to call in need of services, would I primarily be greeted by Justin, or would I be immediately connected with a health services provider like a nurse practitioner like Jody? How does that generally work?
So currently we have a front desk, and the front desk person does an initial assessment to make sure they match having suffering from OUD or AUD as well. And then they put them with a care advocate who does that assessment, the next kind of step of it, and then they would meet Jody. After they meet Jody, and she runs through, the whole litany of things to make sure that we're going to be able to help them and get them started on their medication. Then Jody comes to the peer coach team, and then we get matched up based on the state, because we're in Alaska and Washington as well, state, area, and then any, cofactors like veteran status, specific AUD, specific OUD, anything that we can do to try to match with our peer coach team.
Gotcha. Okay, that gives me a better sense of it. Thank you for that.
Yeah, and then people can go to our website too, and then you can actually help suggest or get people services through that as well. So, but other than that, we don't have any major updates today. I told Jody though that she would give me more cred because she lives down there. So thanks again, Jody, for coming. I appreciate it.
We were getting a little skeptical of him. It's nice that he's got some Southern Oregon street cred now.
It's very important. It's very important. Being a Portlander is not always its best. And this, just kidding, guys. Just kidding.
No, we appreciate you, Justin. Thank you very much. And it's great to have you here, Jody. So Dane with HIV Alliance.
Sure. Well, number one, we did get the prime peers up and rolling. We have two in Jackson County, Sarah and Jade, and they're actually over at Jackson County Health Department today doing naloxone during the syringe exchange. But as far as naloxone in the last quarter, we did 46 new clients, 136 refill clients. That comes out to be about 237 doses for new and about 511 refill doses. And in Jackson County alone, we saved about 28 reversals were identified. In Josephine County, we did about 34 new clients during that last quarter, and then 76 refill clients, about 128 new doses, 280 refill doses, and saved 22 lives. So I think that's pretty tremendous. We do syringe exchange in Josephine, so I can give you kind of perspective. During that period, we had about 365 clients. 122 of those identified as multiple exchangers. And so we actually are hitting a broader spectrum than we will. And I'll try to pinpoint how many that 122 identifies, because as an agency last year for 2020, we had 50 or 3,800 multiple exchangers for an increased amount of about 17,000 people they were serving through our syringe exchange. So that's pretty tremendous when you really look at that. I'll try to pull that out each month, but for that period, that was about 48,000 syringes that we gave out and about 4,500 coming in. So that's a lot of syringes for Josephine County. But that's pretty much our update. But I think the Prime Peers up and running will be great for Jackson County and referrals for assistance, because Prime Peers do work. I mean, we've seen the model here in Douglas County, Josephine County with the Oregon Hopes Project, where those peers and helping them navigate the systems, it really helps them, connect them to care and things.
No, that's great to hear, Dane, and we'll look for some updates moving forward as they continue to do their work. So thank you. Great. I think Cynthia had to leave us. She said 3:45, and it's exciting. I'll just note that their Medford clinic has been up and running for quite a while, and they continue to work here in Medford as well as Ashland. Always great to have them partnering in this meeting. Sarah Smith with La Clinica. I have you under La Clinica, but
Okay, I'm in La Clinica. Thank you. We have 18 providers who can prescribe buprenorphine for people with opiate use disorder. 3 of them are midwives. Our time gap to get services is a week or less. It just depends on conditions at various clinics with different providers. We have had some people present asking for methadone, which of course is not something that we can do. So we network back to our partners, but I'm not quite sure what's going on with that. And then next month in April, we'll be starting kind of a trial contingency management in one of our clinics, and then see if we can spread. So another ripple from dropping the rock in the pond at the LADPC, right?
I think it's great, and I'm so appreciative of Dr. Mann's presentation, and we'll have to get an update from you. I mean, that's the one thing that when somebody mentions something here, I do love to follow up, because it's going to be neat to see what happens with it. So, all right. Thank you, Sarah. Did Julia or anybody from Max's Mission get to join us today? No? Okay. Kyle Gray with Medford Treatment Center.
Kyle's not in today, but this is Joanna. I'm the clinical supervisor for Medford Treatment Center, so I'm gonna give you a little update.
Absolutely, thank you.
So the Matrix building that we've been renovating, which is the building right next door, the top story, that's pretty much has been completed. We're just kind of finishing up the last little bit, getting furniture in there, and we're hoping to move the Matrix program from the main building over sometime next month, hopefully by the end. And then our contingency management program has been doing really well. And we had 4 brand new clients with stimulant-free drug screens this week, along with some that have been having ongoing stimulant-free drug screens. So that seems to be doing really well. So those are the 2 biggest updates right now.
Joanna, a quick question. What are some of the contingency, some of the prizes or rewards that you've been given that have been people are most excited to receive?
So the way that we have ours set up is using the gift cards, and we have it set up as each week with a point system. So their first stimulant-free drug screen, that is level 1, and that is 9 points, and that's kind of like, we start them off a little bit high just to kind of, the big one is always like a really hard one to get. And so then the next week, their second stimulant-free drug screen would be additional 3 points. And then, going on from that, the third one would also be another like 3 points. The 3 points equal to dollars. And so they have, through this program, 23 weeks, they can end up getting a total of $75 total. If they relapse in the middle of one of the weeks, then they go back to level 2, which is the 3 points. So they can't ever re-get those original 9 points. But we have different vendor gift cards. So we have anything from Dutch Bros to Amazon gift cards. And so they get to pick depending on what they choose to do with their points. Some clients are actually deciding to save them and they bank them. And so we just kind of keep the rolling tally of that. And then when they decide that they want to kind of cash out, then they choose that corresponding vendor that they want to get the gift card from.
exciting. I'm really curious about it right now, and I think there's a lot of energy around contingency management in the community. So finding what works and what does get people bought in and excited, I think is really valuable. So thank you very much. And Oasis, I think we have Kristen Johnson and Carrie Hecox here today. So we would love to hear from you guys.
So some updates are we have a pediatric family nurse practitioner that's joined us. So that's been really nice for families and being able to see more kiddos in here. And we're excited that next month our certified nurse midwife is joining, and we're starting to schedule patients, pregnant patients with SUD, and developing that program. So I look forward to being able to share that, hopefully at the next meeting, a little bit more of the structure of those visits and what that's going to look like here. So
that doesn't mean Dr. Hecox has to take OB call, does it? And go deliver babies? Okay.
You'll never sleep again. Yeah.
Right.
So.
No, thankfully not. But no, it should be, we're going to be able to do both the SUD care and the prenatal visit all at one visit, which I think is going to be great. And then we also had our mental health practitioner just started, who does family and marriage therapy as well. So couples counseling for patients kind of in the early stages of SUD recovery is going to be really beneficial, I think. And then a piece I'm really excited about with some of our kids who have behavioral disorders. We now have our early childhood specialist and an adult therapist who can kind of work on that, repairing that dyad from different perspectives, which I think will be really cool.
That is, and I think that's always been central to the vision of the clinic, is the idea that, you do treat the whole family and you look at the parenting and the children. And I think that's such a neat piece of the model. So neat to hear. Thank you both for joining us. All right. On track, Eddie Wallace. Eddie.
Hi. Hey, everybody. Well, on the heels of Kristen and Carrie checking in, much gratitude for them for enabling the staff and clients here to get vaccinated. So thanks again. I don't know how you juggle everything you do, but thank you. Everything going forward at On Track, no new news to report. I checked in with the residential programs. I believe that we may have some spots at both the MOMS program and at Mountain View Recovery up in Hugo. So hit me up in the chat if you want the numbers up there to check in. And I think that's about it. Just grateful for all the information being shared.
Always great to have you here, Eddie. Thank you. And I do, in the era of Zoom, if there's a way to do a virtual tour of the Hugo campus, or even the MOMS program and the changes you've done, I think that's really, both of those are exciting. So
that would be fun. Yeah, definitely.
Yeah. All right. John Baum with Phoenix Counseling.
Hey, good afternoon, everybody. I got a mouthful here, so I'm going to do my best to say it clearly. Back second half of last year, we put a focus on co-occurring disorders, and we were evaluated and approved to be a dual diagnosis capable agency. And, we started rolling out group at the first of the year. And already the reports that we got, it's going so well that we're going back under reevaluation right now to become a dual diagnosis enhanced in agency. So I think that's really good news. We have 11 QMHPs they also have substance use training, and we have 6 interns graduating in June, and we were looking to keep 3 of them. So good news from our front, and again, appreciate everybody.
Very good news, John. Thank you. That is really exciting. So outstanding. We do have partners from the Oregon Health Authority here today. I saw Dr. John McElveen was here, as well as Greg Bledsoe. So if either of our representatives from OHA want to give us updates about what is happening at the state level, we'd love to hear from it.
I'll go first. I think John will probably have something to say too. Yeah, it sounds like some really good stuff happening in Jackson County. So I'm glad to be here and hearing all that good stuff. That's great. I don't have any earth-shattering 110 news or 1115 waiver revelations. I just, we're sort of in a holding pattern on both those sort of the big things that are happening. I would share a little bit what I am doing and have been doing, I guess, for the last 2 years since 2019, which is regarding to House Bill 2257, Section 4, which is the accreditation requirement for national accreditation requirement for all SUD providers in Oregon. And we've been meeting as an advisory group for quite a while. We took a pause because of the COVID-19 issues, and everybody had to tend to their agencies for the first 6 or 7 months of that pretty closely. So we paused our work, but we do finally have some draft recommendations that will go to the legislature. Prior to that, we're going to have 2 listening sessions, and that is, I believe, April 16th and the 21st. Don't quote me on that, but what I'll do is send a flyer to Eric Geyer and kindly ask him to send that out to the rest of the members and anybody else you feel like should be there to listen and provide input to the group.
We'll get that out for sure.
Okay, I'll send that right after the meeting, Eric.
Great.
I would appreciate that. So I think that's all I have right now. I think, hopefully we'll have some 1115 waiver news shortly here. They've been saying that for 3 years, but I'm confident this time that it'll actually happen. But anyway, I'll pass the rest of my time over to John if he has anything.
Thanks, Greg. Dr. McElveen. He may be called away. All right. So our final community updates were, Sarah, do you have any information on the OPGNWG? Oh, I think you're muted.
There we go, a little hand-eye coordination there. But I guess the only thing I'd like to say is that there is this naloxone group that Dr. Shames and I started about 6 years ago. And the idea is in a variety of settings, linking patients, community members with the overdose reversal drug. I think when Dane reports out and he's able to say that at least among clients, they know that 28 lives or 22 lives are saved, it's really good feedback that it's helpful. So we meet once a month for an hour, and if you have any interest or time or whatever to learn more about how we're getting naloxone out into our community in a variety of ways, contact me. The other thing is that there's HB 2376, but it would require that prescribers offer naloxone to people who are getting relatively high risk prescriptions to me, offering is not really the same as making sure that somebody has it, but it's probably a good start. So I think that has a hearing tomorrow in the legislature. So thank you very much.
Thanks, Sarah. Appreciate it. And I don't know if Dr. Trotta was able to join us today. All right. Were there any other guests that I missed who had an update or a comment? Mr. Wright, and I see that you were able to join us. I know you were working with the legislature in your capacity as president of the Federation of Oregon Parole and Probation Officers president. So thank you for your work on that front. Any other updates?
I have no updates, and thank you, Eric. I'm happy to be here after that.
All right, I bet. So, all right, folks. Well, we'll get back together next month. And as always, it's such a great opportunity to see everybody. So thanks for the good work, and we'll talk soon.